I found that talking with other medical students or with my attendings about my experience and how I was feeling, the numbness and the exhaustion with hearing all of these stories. And I found that I was definitely not alone in that, and that many people experience vicarious trauma, and talking about it and being open about it, I think, was the most helpful thing for me.
So happy Friday to all of our listeners, and welcome to Shrinking Burnout, a podcast by two psychiatrists that explores clinician burnout in medicine. My name is Dr. Varsha Radhakrishnan, and I'm joined here by my colleague, Dr. Andy Wu. And today we are here to talk to you about a very important and particularly salient topic that overlaps a lot with burnout: vicarious trauma.
Hi guys, this is Andy speaking. And today we brought a special guest to join us for this discussion on vicarious trauma.
Hi, I'm Allison. I'm a psychiatry resident in the Northeast.
So Allison, why did we bring you here today?
So I wanted to share some experiences about vicarious trauma in my work as a medical student and a resident.
So this topic is especially important to praise and discuss in the context of this very prolonged and exhausting COVID-19 pandemic.
But before we reflect on our own personal experiences, let's talk about some definitions. We've used a couple of papers in our research on this podcast episode, and we'll include them in our description if you guys want to take a better look at them.
Vicarious trauma, or as some people call it, secondary PTSD, this can happen as someone listens to another person as they recount their trauma, or can happen with repeated extreme exposure to the details of traumatic events. An example of this in the context of COVID-19 would be like the vicarious trauma that ICU staff experienced from witnessing multiple deaths and from coping with the complicated emotional stressors related to communicating with family and of dying patients.
Another term that comes up frequently in this discussion is compassion fatigue. This is a phenomenon observed among caregivers caring for traumatized individuals that often results in the caregivers themselves experiencing emotional or psychological distress. This term is frequently interchangeable with that of either secondary PTSD or vicarious trauma. Typical symptoms when we think of PTSD are things like the re-experiencing of the trauma with intrusive thoughts, hypervigilance, avoidance, and other depressive symptoms. In clinicians exposed vicariously to trauma, you can see similar symptoms with that of PTSD, including insomnia, irritability, physical decline, fatigue, loss of appetite, hopelessness, you name it. Involvement as a provider in continuously disappointing and emotionally draining situations can lead to moral distress in clinicians or caregivers, along with this profound sense of powerlessness.
So what about the relationship with burnout, vicarious trauma, and compassion fatigue? There's a lot written about the differences between all three of them. And the way that we talk about compassion fatigue and vicarious trauma is frequently discussing how clinicians have reduced capacity to hear about the suffering of patients. This can be thought of as the cost of caring for others. If we recall our previous definition of burnout, we often characterize it as an occupational phenomenon. Frequently, it's associated with a decreased sense of personal accomplishment, depersonalization, and emotional exhaustion. And when we think about compassion fatigue and vicarious trauma, there's very clearly an overlap in symptoms experienced by providers in the setting of all three of these. The decreased interest, the avoidance, the exhaustion, all of these things can lead to an increased risk of clinical error, decreased efficiency, engagement with maladaptive coping strategies, and a whole bunch of other stuff that makes it a very concerning thing to think about. So with these definitions out there, let's talk more about our own personal experiences of vicarious trauma. So Allison, you're on here as our guest today. Why don't you talk about some of your own personal experiences of vicarious trauma?
I would say that in both medical school and now as a resident, I have experienced vicarious trauma. Specifically back in med school, I would say that we didn't really have a name for this. I just recall some times when I was working in the Veterans Mental Health Clinic doing outpatient work as a medical student. And I was seeing multiple patients with significant trauma history in a workday. I would see multiple people back to back. and they would relay pretty detailed trauma history. I remember initially being surprised at how open people could be with telling you about their past trauma, and that they felt safe enough with you to talk about these things. And that felt good, that you were able to be there and be a supportive person for them. I did notice that after doing that for a while, I started to experience some of those symptoms that Varsha and Andy, you both talked about. Symptoms like feeling of numbness, or feeling of powerlessness, or the exhaustion of hearing so many distressing stories. I began to think that I was feeling less present with the patients when I was with them, and that itself could be harmful for me, but also for the patients.
With respect to some of the emotional exhaustion and fatigue that you described, were there things that helped in those moments when you were feeling that way?
I think as a medical student, I first struggled with knowing what to do with those feelings and how to feel about the feelings itself. I think that I was questioning, is this normal? Is this something that, is wrong? Am I the only person going through this? And so I found that talking with other medical students or with my attendings about my experience and how I was feeling, the numbness and the exhaustion with hearing all of these stories. And I found that I was definitely not alone in that, and that many people experience vicarious trauma, and talking about it and being open about it, I think, was the most helpful thing for me. I found more as I went on to residency of different ways to cope with these feelings and different ways to help with them. I think that things like having your own therapy, it can be really important and really helpful. I think that spending time with people outside of work, where you don't talk about what's going on in work and actually, be able to experience your life, I think can be helpful as well.
Well, I do think, as a physician, or at least as a medical student starting out, you're already in a position that you're, brand new, you're vulnerable, you're not quite sure what is appropriate to feel, think, do. And in that setting, it's also a particular type of setting where I feel like, when I think about my experience as a medical student, I felt like often I had to be more aggressive or tougher or try to stand out. It's a very competitive kind of atmosphere and environment or mindset. And in that setting, I often found myself wanting to at least put forth the sense of confidence and to sort of ignore all those other aspects like fatigue or exhaustion. And I feel like it wasn't necessarily as openly talked about.
Yeah, and Allison, I would just really emphasize what you were saying about these feelings that you're experiencing as a medical student. And to really build off of what Varsha was saying, when you're a medical student, you're sort of like a fish out of water, and you're kind of plunged into a lot of these situations where you don't really know what's going on. And when you're in these situations and things are kind of unfamiliar, and in your situation, you're hearing a lot about some pretty horrific stuff that happened to these war veterans, then having a reaction to that, or being able to even talk about something like that to your peers or to your attendings, that step can seem really hard. I also had these feelings when I was a medical student, and I worked overnights in the emergency room. Whenever there's a trauma going on and we would see some pretty horrific stuff, your body just somehow, reacts differently to it. And you have these thoughts, and it doesn't, I don't quite know how to say it, but it's sort of like your body just wants to go away, or your body wants to run. And there's sort of like this anxiety or fear response that happens.
Absolutely. I think that's an interesting perspective of feeling like your body is reacting differently. And it kind of goes to show that almost that push and pull kind of feeling that you have, where in that moment, you want to be present, you want to help this patient and do your job. And then there's this other part of you that has this intense, almost like physiologic anxiety that you're experiencing. And I think trying to wrestle with those two feelings can be really difficult.
The other thing that I really wanted to emphasize is that when you're a medical student, you really want to do what's best for the patient, or that's what everybody tells you to do, from the medical school curriculum to your attendings to the residents that you're working with. And you want to be able to project that sense of confidence. You want to be able to project that sense that you're ready for anything that you see. But the problem is when you're the medical student, you actually haven't seen a lot of these things. And a lot of the stuff that you're actually going to see is quite scary and quite unfamiliar. And I think that this experience, when you're trying to wrestle with what's been told to you to be able to be the best medical student ever, compared to your own bodies and your own thoughts of what a potentially safe situation would be, really come into contact. And that's sort of what causes this vicarious trauma. And, I guess I was wondering if any of you guys had any sort of thoughts on this as well.
Well, this brings up actually a very recent conversation I had with someone. It was one of my friends from home who had asked me, how do you walk home from all of these like horrific stories and things that you're dealing with? I know as psychiatrists, we're very particularly in a situation where we're more so hearing and listening to our patients' very painful and deeply traumatizing stories. And we really do get very deep into the painful feelings that they experience. And so it's a little bit different from that classic experience of walking into an emergency room and seeing something visually horrific. We're more so sitting there and chronically listening in a long-term sense of all of these different painful experiences. And so part of me, I remember thinking, I don't really even know how to answer this, because I go home and I try to move on, like I try to separate myself and create very strict boundaries with work. But there are times when that emotional exhaustion pours over and I, start to ruminate and think about, what did I really see today? And I guess what has been difficult for me in particular is this feeling where I don't want to seem emotionally jaded, that whole idea of, not being interested anymore in what the patient has to say. But part of it is protective in some way, protecting myself from really becoming almost enveloped in our patients' stories and their lives. And that can be a really, really difficult thing to find the balance with. And I'm still struggling with that.
And Varsha, you mentioned on a previous episode that burnout technically is really known as a work-related phenomena. But the problem with burnout and clinicians is that a lot of clinicians take their work back home. And in the case of being able to be a psychiatrist and hear about all of these stories from these war veterans and these other patients, when you go home, it's really hard to kind of turn it just all off. And you do end up thinking about stuff that happened at work. And then you do end up ruminating about that. And that's sort of when the burnout phenomena really goes beyond that of just work.
And that what's really interesting and unique about this time in particular is that we don't have that natural separation of space when we're seeing patients right now, because a lot of what we're doing right now is telemedicine. So you're seeing people from home. You turn off your computer and okay, technically I don't have any more patients to see for the day, but you're still in that same space. And what I found to be really difficult, especially right now, is feeling like I can't separate myself from that. And so when I'm hearing from a very depressed patient how they're having suicidal thoughts or feeling really overwhelmed and isolated in the setting of this pandemic, I may finish a session, but I find that feeling of being sucked into that void is pervasive. Like I can't really shake it. And so I find that when I am talking to friends, family, outside of work, I notice a change in sort of my own mood and the way that I'm reacting to things. And I think part of it is definitely that difficulty with establishing that boundary.
And really, just to emphasize that, Varsha is really talking about her experiences being a psychiatry resident and really hearing about these patients that she's taking care of. But I would say that in the case of vicarious trauma, it's something that I think a lot of clinicians, not just psychiatrists, really are struggling with. And, it may be that as psychiatrists, we're a little bit more attuned to really wanting to talk about our feelings or discussing our feelings. But like I was saying before, when you're a medical student and you're on all these other services, not just psychiatry, you still have these feelings that arise. And there's still a lot of trouble that can happen when you have to try to make sense of all these emotions.
There's also a different side of vicarious trauma that physicians or providers experience, which can be hearing not only the traumatic events that has happened to the patient, but specifically in forensic psychiatry, You hear a lot about what has happened to victims of a patient, and that can give you a lot of different feelings. Listening to the stories of patients who are coming in that have capital murder charges in Arkansas was something that I found really striking, because some of these patients were very ill. They were patients that had severe mental illness, but they were also patients that had committed very serious and very disturbing crimes. Some of those crimes were murder. Some of those crimes were very disturbing sexual assaults. And hearing that can really take a toll on you, that, you begin to kind of feel that, what am I here for? What am I doing? Am I helping? Am I being any use for anyone here?
Well, I think, Allison, you bring up a really good point in that, especially in that particular situation, you're hearing about what your patients may have perpetrated, the crimes that they have perpetrated, and you're filled with all of these complex, conflicting emotions. Part of you, it sounds like, is wondering, how can I actually help this person? The other part is like, do I want to even help this person? And that can be a hard, guilty feeling, not really knowing where you stand and what you're supposed to do. And I think it links back to that overall or overarching feeling of powerlessness that tends to accompany a lot of these feelings that we have with compassion fatigue and that depersonalization, as we had talked about before.
And now we wanted to talk about the ongoing COVID-19 pandemic and how it's really affected clinicians in terms of discussing vicarious trauma that they experience.
So this time period has been especially difficult during the COVID-19 pandemic, where we're all exhausted, fatigued. I think this term that was used that I saw in the news, the idea of pandemic fatigue, just feeling like you're at your wit's end. And I think the challenging part of it all is, even as a clinician, you're in there with your patient. You know exactly in a lot of ways what they are experiencing because you're experiencing it yourself.
Allison, you mentioned that some of your co-residents experience maybe some form of vicarious trauma when they're rotating at the children's hospital.
Andy, yeah, I agree. I think that some of the experiences with working with children in the COVID pandemic have been unique and have been scary to see. Hearing children recount their trauma in general is really difficult. I think for me, talking to children about trauma is the hardest thing. And I take that home more than I do with adults. And hearing some of my co-residents talk about the trauma specifically surrounding COVID, and hearing children that have lost grandparents or lost parents to COVID and how they recount that. And that's all also going around with all of the other things that are happening in the world. And as a child, that can be just intense. And the way that they describe it can really sit with you. And that the feelings that come out of that as a provider of wanting to, help them, but feeling powerless, and that you're not going to be able to change the world right now. Like, you're not going to be able to just turn off the pandemic. You can't take them out of that setting. It feels powerless.
Yeah, absolutely. I mean, especially with children, you want to do what you can to try to make things better and you want to fix the situation. But, especially with children, sometimes I wonder, how much are these children really understanding about the situation? Especially when I think about my patients, who I work more with an adult population, and a lot of my patients have young children. And so they're struggling as well with not really knowing what to do next. How do they explain what's going on to their children? Why can't their children play with their friends? Why are they cooped up at home by themselves and isolated? I feel like, especially over the last few months, I've been hearing a lot about stories from my patients about how anxious and distressed and overwhelmed they're feeling, separated from friends and family. I have patients who are even struggling financially after losing their jobs, or I've met teachers, especially during this pandemic, who've expressed having difficulty managing and engaging children virtually. I mean, this has presented so many new challenges that are really truly unprecedented and things that we don't really know how to deal with yet. And, as I mentioned, with many of my patients that are parents and have young children, there's really an extra added layer of challenge and difficulty that comes with that, of wanting to care for your child and be there for them at home, but also now having these new responsibilities of also working from home, having to try and figure out what to do next. As I mentioned, financial stressors on top of everything. And then there's this chronic feeling in the background of feeling afraid. What if you get sick? What if something happens to someone that you love? And so I think what really comes to mind is this interesting role that we're playing right now as psychiatrists. We're not technically on the front lines in the ICU, running ventilators for patients, but we're in a very unique and particularly challenging position.
And Barsha, really just to add the complicated role that psychiatrists play right now, I'm seeing a couple of patients who are working in the ICUs, and being able to kind of hear about their experiences secondhand really makes me think about the potential risks that I have in terms of incurring any sort of vicarious trauma. And, we mentioned the term compassion fatigue as well, where whenever you have a really busy day and you have a lot of these patients that are really looking for you as a psychiatrist or you as a therapist or a source of support. And oftentimes, when you've had a very busy day, it's really hard. And sometimes you do feel worn down and you do feel like the compassion reserves that you have are really running low. And, when you're kind of in that position, it kind of places you in that difficult spot where you're kind of thinking, I have to do what's right for my patient. And also, I'm really tired. And how do you really reconcile those two?
And how do you make sure that you're not over pathologizing what really is in some ways an almost normal response to these completely horrible circumstances that we're in? That's another thing I found to be particularly challenging, is speaking to my patients who are feeling more depressed and lonely and exhausted. And part of me is thinking, yeah, I feel the same way. I'm there with you. And that point I'm thinking, is this person severely depressed? Is there something that I need to be thinking about from more of a psychiatric diagnostic perspective? But I mean, the reality of the matter is this sucks. This is a horrible time. And I think that feeling of powerlessness is so pervasive every single day.
So, with all of the risks that clinicians have with incurring vicarious trauma and compassion fatigue, especially with the COVID-19 pandemic going on, let's talk about some potential solutions that have been proposed in the literature and also our personal experiences with these potential solutions.
When thinking about solutions, I go back to my medical school experience of talking with these veterans and hearing their traumas. I noticed that it wasn't just me, and that there were many medical students that were feeling similarly. And my medical school began to think about ways of how we can work with this and how we can try to find solutions that could be helpful for medical students without making it feel like you're having another job or this is another thing that you have to do. This is a requirement. And we ended up doing an informal process group. And a process group can be a lot of things, but for us, it was having a psychiatrist come and let us just talk about our experiences and what we've been through, listening through all of these different hard and traumatic experiences of our patients. And I just recall one of my colleagues who broke down in tears when he described a child that had been hit by a car, and that how he had to care for that child in the trauma bay, and how all he could think about in that moment was his children at home, and picturing that, is his child and how the family must feel. And it was just striking to me because he shared this and how it was so hard for him, even weeks later. This was, many weeks later, that he was still feeling that and still thinking about that. And he shared that with us, and everyone in the room really felt that. And we all were able to share how we had similar experiences. We might not have children at home, but we might have a grandparent or someone that we felt that we were really thinking about, or that we were having these recurring thoughts or ruminations. And the psychiatrist there would kind of talk us through this and normalize that these are feelings that a lot of medical students, a lot of providers, even psychiatrists have. And that, talking about it with other people and hearing that you're not alone, I think is incredibly helpful. And I remember the other medical student who had talked about seeing that child, that he said that it was helpful for him to talk through it and being able to share his story.
And Allison, I think what you mentioned about the process group is something that can really be beneficial for a lot of people. But some people, maybe the process group aren't actually logistically there for them, or they're not actually able to share in a setting like that. But I think the gist of it is that being able to talk about your own experience, being able to acknowledge the feelings that you're having about the experience, being able to say to yourself that I had this experience, these are my feelings, and it's okay that I have these feelings. That last statement of it's okay to have these feelings, that's actually something that it's easier said than done, and sometimes it's a pretty long process for clinicians to actually start to believe in themselves that it's okay to have these feelings.
Yeah, and it definitely also brought to mind the value of the process groups that we have currently in our residency, which is basically called Becoming a Psychiatrist, these small groups with our colleagues in our class. And I found that to be so extremely valuable. I think the one important part is feeling like you're not alone. And the other part is feeling like there's a safe space to be able to talk about these complicated emotions and feelings that you're having in a very non-judgmental atmosphere. While we're on this topic, I think it's important to also talk about other strategies to help decrease burnout and decrease this extreme depersonalization, numbness, and exhaustion that occurs with compassion fatigue and vicarious trauma. One of the things that I found to be helpful and that I've seen in literature is limiting the amount of exposure to media, focusing on the pandemic, politics. If that's something that increases your anxiety and distress, I think trying to limit the amount of exposure to that can be helpful. The other thing that we had touched upon is the idea of starting process groups. If that's not available, I think the other key piece is to be able to communicate with close family and friends, people that you trust.
And Varsha, just to really build on the sense that you said, is that the value of having a safe space. And if the safe space is a process group where you're able to talk about it with your colleagues, great. If the safe space is basically being able to talk about it with an individual counselor or therapist, that's great too. And if that's not for you either, if you're able to have a safe space with just your peers from work informally when you're kind of off work and being able to debrief and talk about it informally, that's also a pretty good way. And all of these ways, like having a safe space, even among supportive family members to just be able to talk about it, that's also a way in which you can really get a better sense of the vicarious trauma that you may be experiencing when you're a clinician.
And to add to that, it's also okay if you don't want to talk about what's going on. I think the key here is that it's ultimately up to you, what you feel comfortable with, what you feel safe with doing. Your safe space could be more so a space for you to meditate and feel calm, and you don't have to talk to people and you don't have to talk about your experiences, because that's also exhausting to have to completely rehash and relive some of the difficulties that you're dealing with day to day. And that's really, I think there's no right answer here, is what we're really seeing as to how to deal with this and what to do. I think ultimately what we're going to have to do is just slowly work together and figure it out and support each other through the way.
Those are great words, Varsha. Well, this is sort of the end of our episode today. Thank you, Allison, for joining us on this episode and for sharing your personal experiences.
Thank you, Varsha and Andy, for having me here today and giving me this outlet to talk about my experiences and share them with the community.
And thank you to everyone for listening and supporting us. This has been such a difficult and exhausting time, but we will get through this together. Tune into our future episodes on LGBT healthcare and the experiences of sexual and gender minority providers who have experienced burnout. As always, if you have suggestions, questions, comments, or are interested in being featured on the podcast, please email us at shrinkingburnout@gmail.com and follow us at shrinkingburnout on Instagram. Your anonymity and privacy is important to us, and we will do what we can to protect your identity.
Shrinking Burnout is a podcast focused on furthering the discussion of clinician burnout. The views and opinions expressed on this podcast are solely our own and do not reflect those of our medical institution.